Electronic fetal heart rate monitoring provides a live readout of a dynamic physiological circuit. Every fluctuation across the monitor strip is a direct manifestation of the fetal central nervous system. The most critical feature of this tracing is baseline variability. This jagged line represents a constant tug-of-war between two competing forces. The sympathetic nervous system acts as the accelerator, driving the rate up, while the vagal system acts as the brake, pulling it down. When these systems are fully oxygenated and firing normally, they create a fluctuating bandwidth of 6 to 25 beats per minute. This moderate variability is the definitive proof of an intact fetal brain and the absence of severe metabolic acidosis. If that jagged line flattens out to fewer than 6 beats per minute or becomes completely smooth, the autonomic tug-of-war has stopped. This depressed baseline indicates a loss of central nervous system drive, but it doesn't immediately confirm hypoxia. Clinicians must first rule out reversible causes. A healthy fetus often enters a sleep cycle that can smooth the tracing for up to 40 minutes. Additionally, maternal medications like opioids or magnesium sulfate cross the placenta and temporarily dampen fetal neurological activity. Establishing baseline variability is the mandatory first step in interpretation. It measures the functional reserve of the fetal brain before it is subjected to the mechanical or metabolic stresses of labor. As labor progresses, uterine contractions apply physical force to the fetus. These mechanical stresses trigger specific waveforms on the monitor, known as decelerations. Early decelerations are a benign vagal response. As the contraction squeezes the fetal head, it briefly alters cerebral blood flow, stimulating the vagus nerve and slowing the heart rate. This pattern perfectly mirrors the timing of the uterine contraction. The drop begins and ends exactly with the squeeze, signifying a normal physical reflex that requires only reassurance and continued observation. Variable decelerations have a different mechanical trigger, umbilical cord compression. This is frequently seen in cases of low amniotic fluid or when the cord is physically caught between the fetus and the uterine wall. The diagnostic signature is speed. Unlike the gradual curves of other decelerations, a variable drop is abrupt. The heart rate plummets to its lowest point, the nadir, in less than 30 seconds. This sharp V shape reflects a rapid physiological shift. The contraction first collapses the thin-walled umbilical vein, causing fetal hypotension. As the thicker umbilical arteries are crushed moments later, fetal blood pressure spikes, triggering a massive compensatory baroreceptor surge that forces the heart rate down. Those erratic fluctuations at the bottom of the V are the autonomic system fighting to maintain equilibrium. Because the problem is mechanical, the treatment is physical. Moving the mother to her left side often shifts the fetus off the cord. If the compression is recurrent, saline can be infused back into the uterus to float the cord away from the pressure points. Both early and variable decelerations signify that the fetal reflex arcs are functioning. They represent physical compression rather than a metabolic emergency, requiring positional adjustments rather than surgical intervention. The clinical priority shifts when the stress moves beyond physical compression and reaches the threshold of metabolic failure. Late decelerations occur when the placenta cannot deliver enough oxygen to sustain the fetus during a contraction. This is a state of true uteroplacental insufficiency. The geometric signature of this failure is a delayed recovery. Because the drop in heart rate is a reaction to falling oxygen levels, the nadir of the fetal tracing strictly occurs after the peak of the contraction has already passed. Late decelerations require an immediate intrauterine resuscitation sequence. You must stop oxytocin to end the stress of contractions, reposition the mother, and provide IV fluids and oxygen to maximize placental perfusion. If these resuscitation efforts fail to reverse the pattern, the metabolic deficit is too high. Emergent cesarean delivery is then required to prevent permanent neurological injury. A different metabolic emergency appears as a sinusoidal pattern. This is a smooth, undulating wave that lacks any normal, jagged variability. This wave is the pathognomonic marker for catastrophic fetal anemia. It signals that the fetus is losing its oxygen-carrying capacity, either through Rh isoimmunization or acute hemorrhage, and is at imminent risk of death. Late decelerations and sinusoidal waves represent a failing system stripped of its oxygen or blood volume. These are not protective reflexes. They are distress signals demanding rapid medical or surgical rescue. To see how these kinetic principles work in a high-pressure scenario, let's analyze a clinical master case. A 28-year-old mother is in active labor at 39 weeks. She is currently 6 centimeters dilated and has just received epidural anesthesia for pain management. 10 minutes after the epidural is placed, the fetal heart rate baseline drops to 110 beats per minute. The jagged variability disappears, and recurrent late decelerations appear on the monitor. With the tracing crashing into late decelerations and minimal variability, what is the most appropriate next step? The visual severity of this strip often triggers a visceral urge to rush the patient to the operating room. But treating the shape of the waveform without identifying the maternal trigger leads to unnecessary surgical interventions. We can immediately reject operative vaginal delivery. Forceps and vacuums are contraindicated because the patient is only 6 centimeters dilated. She must be at 10 centimeters for those tools to be safe. Terbutaline tocolysis is also incorrect. While it stops contractions, it is reserved for tachysystole and does not address the underlying pathology here. Amnioinfusion is a mechanical fix for cord compression. It cannot resolve the uteroplacental failure indicated by these late decelerations. Even an emergent cesarean delivery is premature. While it removes the fetus from the environment, it ignores a rapidly reversible cause of the crash. The definitive solution targets maternal hemodynamics. Administering IV ephedrine or a fluid bolus restores the pressure gradient required to sustain the fetus. The anesthesia caused a profound maternal sympathetic blockade, triggering systemic vasodilation. As vascular resistance plummeted, maternal blood pressure crashed, effectively stalling the blood flow necessary for placental oxygen exchange. Pushing IV ephedrine or fluids corrects the maternal hypotension, directly restoring placental perfusion and resolving the fetal hypoxia without the need for surgery. The fetal tracing is a live reflection of a shared maternal-fetal circuit. Recognizing the mother's role in this system allows for targeted resuscitation, where the most effective fetal cure is often maternal stabilization.